So I posted the website for your review, but here it is again. If you didn't print it out or anything, or for the people who are watching at home, you can go to this website, sites.google.com/site UCF Study Union/home, and the review will be PCB 3703 final review. Okay. Can you guys see this? Is it good? On the side in the middle of each table, there's something for a survey. There's like a QR code or a website. If you could, at the end of the session or in between if you have time, probably not, do the survey if you could. All right, it helps us for Study Union to see what you guys want more of. Okay? So exam 5. Exam 5 is going to be on the endocrine system, reproductive system, and because immunology wasn't on your last test, it'll be on this test. Okay? I just want to remind everybody that you're going to need to look at the BRS questions. As always, there's going to be a few free ones. I didn't study the pathology book, but previous students have said that there are questions from there. Great. If you have any questions, we'll just say that towards the end. Or if it's something that you really need to know, just like start waving at me and then I'll answer it. Sounds good? Okay, let's start. So the endocrine system uses hormones, right? And these will travel through the bloodstream. All right, so the hormones travel through our bloodstream and act on its target cells, usually within endocrine glands, right? What other system in the body uses information flow? And is it faster or slower? Does anyone have an idea? So we have our endocrine system, and then we have, exactly, the nervous system. Now, would the nervous system be faster or slower than the endocrine system? Exactly, it's going to be faster. Now let's go over the types of hormones and secretions. The first, we're going to talk about endocrine hormone secretions or the endocrine system. This is the process of secretions into our bloodstream or the circulation. All right. So which secretions act on neighboring cells? You guys know? Starts with a P. Paracrine, exactly. Paracrine hormones or secretions will act on neighboring cells. These can be agnostic or antagonists, or agonists or antagonists. What about secretions that act on its own self? Autocrine. Right? And when it's within the cell or inside, intracrine. I'll write it out. So as you're studying these different hormones and their secretions, they're sort of self-explanatory, right? If you think about the definition, you can figure out the type, all right? What about hormones or secretions that are from duct secretions into cavities outside of the circulation? Exocrine, exactly. Synergistic just means the hormones work together. Permissive, as you can see, the second hormone increases activity. The first hormone increases activity of the second, right? An agonist, antagonist, what happens with an antagonist? It works against, right? So one hormone will work against. Okay, I ran out of space. What about agonists? So antagonist is working against, and agonist will work with or as the same. It's just the exact opposite of antagonist. Protein hormones will bind to what kind of receptors? Right, a cell surface receptor. Precursors for protein hormones are amino acids. They are lipophobic or hydrophilic, and they're going to travel freely, right, freely in the blood. They don't bind to a specific protein to travel within the blood, they just travel freely. So I want you guys to memorize this list of cell surface receptor hormones. Growth hormone, prolactin, parathyroid hormone, insulin, ACTH, glucagon, somatostatin, and adrenaline. All right? Check that in your notes if there's any more or less. Steroid hormones compared to protein hormones, what do they bind to? Nuclear receptors, right? And their precursor is cholesterol. Again, these are lipophilic or hydrophobic. And we said that protein hormones, they travel freely, but steroid hormones will travel bound to a what? A protein, right? Again, make sure you guys know the hormones that will bind to these receptors. Vitamin D, T3, T4, sex hormones such as testosterone, estrogen, progesterone, and steroid hormones such as the sex hormone androgen, aldosterone, and cortisol. Okay? There's going to be some questions throughout the review. I want you guys to do this on your own, or if you find a previous review that answered it already, because we're going to move on pretty quick. Okay? So reception of hormones. There's going to be 5 different types that we talk about. First one is GPCR, which is G protein coupled receptors. These are coupled with GTP, right? GTP is guanosine triphosphate. G protein has how many subunits? Kind of count it right there. 1, 2, 3. So how many subunits? 3, right. So which one of these 3 subunits has an inhibitory or stimulatory effect? Right, alpha. All right, so the mechanism is going to start with a ligand or a hormone that binds to its receptor, and it's going to activate the G protein within the cell, right? This G protein will then activate or form second messengers. Some examples of second messengers will be 1, adenylate cyclase, 2, cyclic AMP or CAMP, cyclic AMP, 3, IP3, which stands for inositol triphosphate, 4, phospholipase C, ranastase. Alright, so once it forms second messengers, it's going to increase or decrease intercellular energy. And once that occurs, the physiological effect of the target cell will happen. Okay? So growth factor receptors, they have a binding domain, and what is this called? Do you guys remember? It starts with a T. I think I heard someone say it. Tyrosine kinase, right? So they have a tyrosine kinase domain. Okay? The cytoplasmic side will act as a second messenger. It autophosphorylates and it will activate further pathways. Okay? What were some examples of factors or hormones for the tyrosine kinase domains and growth factor receptors? Insulin, exactly. So one of them is insulin. Can you guys see that? All right, so we have insulin, EGF. What does EGF stand for? It's like epidermal growth factor, right? I is insulin-like growth factor. So ATP is used in the transverse phosphate to signal cascades for glucose uptake. What type of channel does insulin activate? You guys remember? The channel, though. The channel. It's looking more for GLUT something. GLUT4, right? Know the difference between growth factor receptors and cytokine receptors? The cytokine receptors uses what kind of domain? Right, a JAK2 domain. Which it kind of acts like a tyrosine kinase domain. Right, the whole point of it is JAK2 will bind to a specific hormone together and they'll work as tyrosine kinase. Right? So which hormone will specifically bind to cytokine receptors? It's going to be growth hormone. Right? And growth hormone will trigger cell proliferation, cell growth, etc. Okay? And let's talk about ligand-regulated guanylyl cyclase receptors. It's going to open up a channel and the ion flux acts as a second messenger. Right, and the ligand is going to bind and it's going to activate nitric oxide synthase, which stimulates guanylyl cyclase or guanylyl cyclase. It's going to elevate cyclic GMP, allowing for its physiological effect, vasorelaxation. All right, so nuclear receptors. Which hormones were specific for nuclear receptors again? Which hormones? Steroid hormones, right? Steroid hormones. There's three domains, the N-terminal, DNA binding, and the C-terminal. N-terminal affects the transcription. And what were the different types of steroid hormones and thyroid hormones that bind to nuclear receptors? You guys know this, come on. So the hormones of the adrenal cortex, there's three of them. Right, androgen, aldosterone, cortisol, correct? So let's write that down first. We'll start with aldosterone, cortisol, and androgen. What are the thyroid hormones? What are these two? T3 and T4, right? T3 is triiodothyronine and T4 is L-thyroxine or thyroxine. We have sex hormones, and what are these sex hormones? One of them is androgen. What are the other three? Testosterone in males, estrogen, and progesterone. And another classification or another drug, hormone, there's a vitamin specific one. Which one do you guys remember? Right, vitamin D, correct? Specifically binds to nuclear receptors. Right, they're going to diffuse across the membrane, bind to the systolic, and then the nuclear receptor. When it binds, the DNA binding domain is exposed and will interact and show its physiological effect. You guys can read that. Now let's move on to the relation between the pituitary gland and the hypothalamus. So the anterior pituitary lobe of the pituitary gland will use a certain portal system from the hypothalamus, like the blood vessels. What is this called again? Okay, so it's the hypothalamo-pituitary portal system. Hypothalamo-pituitary system. Another name for it is the hypophyseal portal system. It's more commonly abbreviated as HPS. Now the posterior pituitary lobe of the gland will use axonal fibers from the paraventricular or supraoptic nuclei, right, from the hypothalamus to the posterior pituitary lobe. How many lobes does the pituitary gland have? 3, right. So we have the anterior lobe, the posterior lobe, and third is the intermediate lobe, right? Hormones of the anterior pituitary gland or lobe. There's this acronym that is often used called FLAT-PIG, right? You guys heard of that? No? So anyways, F is FSH, L is LH, A is ACTH, T is TSH, P is prolactin, and G stands for growth hormone, right? Whereas the posterior pituitary hormones are A and O, what does the A stand for? ADH. And O, oxytocin. Exactly. Now question, does the posterior pituitary lobe of the gland produce ADH and oxytocin? No, exactly. What produces these two hormones? Right, the hypothalamus. The hypothalamus will produce them, and then they will travel down the paraventricular or supraoptic nuclei to the posterior lobe to be stored within the posterior lobe of the gland until we need their secretions for physiological actions. Right, here's a picture of the different hormones and different parts of the body that they go to. All right, FSH, follicle stimulating hormone, is a protein hormone. Males and females, it's for maturation of germ cells. In males, it's going to bind, or it's going to induce the testes, right, to bind testosterone and undergo spermatogenesis. In females, it's going to initiate the follicle growth, and it peaks at day 15 of menstruation, also known as the ovulation phase. LH, or luteinizing hormone, in males, it's going to stimulate a certain type of cells. Do you guys remember? Right? Leydig cells. LH will stimulate the Leydig cells to secrete which hormone? Testosterone. And when there's enough testosterone, this will inhibit LH production due to negative feedback. Right? In females, luteinizing hormone is for rupture of the follicle, elimination of the ovum, and migration toward the fallopian tubes during ovulation. An excess of LH can cause premature menopause, PCOS, or polycystic ovarian syndrome, as well as Turner's. Moving on to ACTH, or adrenochromotropin hormone. Again, it's a protein hormone that stimulates the production of the adrenal cortex hormones. What are these three again? We're going to be saying this a lot, guys. Right, aldosterone, cortisol, and androgen. Exactly. A deficiency of ACTH can lead to secondary Addisons, right? So an excess of ACTH, what could this lead to? Right, Cushing's. for TSH, or thyroid stimulating hormone, protein hormone that stimulates the production of the thyroid hormones. These were T3 and T4, right? Deficiency can lead to hypothyroidism, excess hyperthyroidism. Prolactin. What inhibits prolactin? Starts with the D. Dopamine. And prolactin will stimulate the production of milk, right? When there's an excess, it'll suppress sex hormones, or during pregnancy, it'll tell the female's body that she's pregnant, which will suppress sex hormones. Deficiency of prolactin can be due to too much dopamine. Could be excess anti-Parkinson's drug. And when there's an excess of prolactin, this can cause abortion. Prolactinoma, tumor of the prolactin secreting cells, can lead to infertility. Right? So growth hormone stimulates cell proliferation and growth, bone development. What is growth hormone inhibited by? Right, somatostatin. When there's a deficiency of growth hormone, this can lead to dwarfism. When there's an excess, this can lead to gigantism. Now let's talk about the posterior pituitary lobe. We have the two hormones, oxytocin and antidiuretic hormone. Oxytocin will promote milk to do what? Right, ejection or secretion. Ejection or secretion. It's the same thing, ejection, secretion. Oxytocin can be used as treatment for delivery because it stimulates uterine contraction. ADH, or antidiuretic hormone. This will facilitate reabsorption. By acting on the collecting tubule of the kidney nephrons. What is ADH reabsorbing? Right, water. Right, and a deficiency of ADH can lead to dehydration. By the way, another name for ADH, do you guys know what that is? Right, vasopressin or vasopressin. Hormones of the hypothalamus. We'll start off with TRH. TRH is thyroid stimulating hormone. This will stimulate the anterior pituitary to release which two hormones? TSH and prolactin. Right? You guys can read these little tidbits right here. It's just general information. We'll talk more about it as we move on to the review. And dopamine will inhibit which hormone again? Prolactin. It's associated with sleep disorders. Other functions of it are unknown. GnRH, or gonadotropin releasing hormone. By the way, these are all peptide hormones. GnRH will stimulate which two hormones of the pituitary gland? FSH and LH. Right? So somatostatin will inhibit growth hormone secretions. In the pancreas, it inhibits insulin and glucagon. So in the hypothalamus, somatostatin will inhibit growth hormone, but in the pancreas, it will inhibit insulin and glucagon. Right? Growth hormone releasing hormone will stimulate growth hormone secretions from the posterior. No, that's wrong. From the anterior pituitary. So oxytocin and ADH, like we said, they are produced in the hypothalamus, right? And they are stored by the posterior pituitary gland or lobe. So make sure you guys remember that. And CRH will stimulate ACTH secretions from the anterior pituitary, right? Because the posterior is just oxytocin and ADH. Deficiency of CRH can lead to which disorder? Starts with the A. Addison. Is this primary or secondary? Secondary. We'll talk about it. Excess can lead to what disorder? Starts with a C. Cushing's. So we have the adrenal gland, which consists of the adrenal cortex and the adrenal medulla. For the adrenal cortex, we have three hormones: aldosterone, cortisol, and androgen. Know the function of each of these hormones and the symptoms that can arise from an excess of them or a deficiency of them. And the little acronym that they told you guys in lab was girls from Russia make good soup, right? So girls, or zona glomerulosa, zona fasciculata, the F right there, and zona reticularis. The zona glomerulosa, I can't really say that well, zona glomerulosa, right, is in charge of mineralocorticoids. And what is a mineralocorticoid? Which one of these three hormones? Right, aldosterone. The zona fasciculata is in charge of glucocorticoids. And which one of these three hormones is that? Cortisol. Zona reticularis, specific for sex hormone. Androgen, not necessarily testosterone and estrogen because those go through different pathways, but those are sex hormones. Let's mark it out. Okay? So now we're going to talk about the function of each of these three different hormones of the adrenal cortex. Aldosterone promotes vasoconstriction. It increases blood pressure by reabsorbing a specific ion. You guys remember? Right, sodium. You're going to excrete potassium and hydrogen ions. And the reason or the way that aldosterone increases blood pressure not only through vasoconstriction, but as we know, wherever sodium goes, water follows. Increase in blood volume means increased blood pressure, right? So anywhere sodium goes, water follows along with it. Increased water within your body, right? Increased blood pressure. Some disorders are hyperaldosteronism, also known as Conn's disease. Some symptoms are hypernatremia, hypertension, hypokalemia, and acidic urine. We'll talk more about these disorders as the review goes on. Hypoaldosteronism is the exact opposite of all of these. So androgen is a steroid sex hormone. It's going to stimulate male sex characteristics, axillary hair growth from puberty in females and males. Some disorders, androgen insensitivity syndrome, right? You guys can read this here. She didn't really talk about these in class, but it's good to read over if it's in here in the PowerPoints. Cortisol, this is the, I would say this is the big daddy, right? So cortisol, the functions of it is anti-inflammatory, right? Anti-inflammatory response. It increases your appetite. It's an immunosuppressant. Increases your blood pressure indirectly, right? Increases gluconeogenesis, so it has an indirect effect on your blood glucose levels. And it inhibits insulin, right? Some diseases, Cushing's and Addison's. You guys can answer this on your own. So adrenal gland disorders. Let's talk about Conn's disease. What's another name for Conn's disease? Do you guys remember? She likes to use other names for diseases. Was that? So which hormone is being affected for Conn's disease? Aldosterone, right? So when there's an excess secretion or excess production of aldosterone, what is that called? Hyper, right? So hyperaldosteronism. Some signs and symptoms. We already know headache, nausea, vomiting, right? So let's go for the more specifics. What you're going to want to look for is 1, hypernatremia, right? Because the whole role of aldosterone is for sodium reabsorption. When you have excess aldosterone, that means you have excess sodium within your blood. Hypernatremia. Whenever there's hypernatremia, we always know if there's hypokalemia, right? Deficiency of potassium within your blood. And because of the increased sodium in water due to aldosterone's effect, we're going to have hypertension. These are the main symptoms for Conn's disease. You saw previously on the list, there's acidic urine, so keep that in mind as well. Do you guys ever remember seeing treatment for Conn's in your PowerPoints or in lecture? Yes or no? No? Okay. Just in case, treatment for Conn's disease, we can use a drug called spironolactone. I'll just write it up here. You guys see that? All right. Spironolactone acts as an aldosterone antagonist. What does antagonist mean? Against, right? So it's going to block off aldosterone because we have an excess amounts of aldosterone in the body. We're good? Which disorder of the adrenal cortex and its hormones refers to when there's an excess of aldosterone, cortisol, and androgen? Someone say it. It starts with a C. Cushing's, right? First, let's talk about secondary Cushing's. She may not go specific, saying that secondary is Cushing's disease and primary is Cushing's syndrome, but just keep that in mind. We'll go over that again. Cushing's disease is also called secondary hypercortisolism. This is due to elevated levels of which hormone? Secondary. Right, it could be either CRH or ACTH. Right, when there's an overproduction of CRH and ACTH, this will then lead to an overproduction or secretion of the three peripheral hormones, correct? So we have androgen and aldosterone, but the main concern is cortisol. Cortisol has the more detrimental side effects. That's why this disease is called hypercortisolism. Symptoms: hypertension, hypernatremia, hypokalemia, fatigue, weight gain. What's a symptom due to excess androgen in a female, right? Facial hair, right? What else? Was that infertility? Right. Well, deep voice is another thing, but the main ones is hair growth. Right here we'll put infertility. Facial hair or hair growth in women. And there's something with cortisol, if you guys remember, when there's excess cortisol, it'll indirectly affect blood pressure, but what else? Right, blood sugar, correct? So increased blood glucose levels, and this is called hyperglycemia. What are levels of blood glucose indicative of hyperglycemia? If it's above 120, correct? Because normal range is 70 to 110. So primary hypercortisolism is also called Cushing's syndrome. Like I said, I'm not sure if she's going to differentiate them like that. She might just say Cushing's. But just in case. This is directly due to overproduction of cortex hormones. We know that it's aldosterone, cortisol, and androgen. Treatment can vary upon the two. And what's the difference of hormone levels for primary and secondary Cushing's? So we know that it's an increase of all three peripheral hormones, correct? But what about hormones of the hypothalamus? Let's start off with secondary. Levels of CRH and ACTH, what do you guys expect you'll see for secondary Cushing's? There's a tumor, manipulation during surgery, etc. of the tissue in the hypothalamus, leading to excess or deficiency of CRH and ACTH. Which one? Excess, right? And because of the increased levels of CRH or ACTH due to a tumor or etc., there's going to be an increase of aldosterone, cortisol, and androgen. Is that better? Good. All right, sorry about that. So secondary, increased CRH, increased ACTH, increase of the three peripheral hormones of the adrenal cortex, aldosterone, cortisol, androgen, right? Now as for primary Cushing's tumor, manipulation during surgery, etc. of the adrenal cortex and not the hypothalamus or the pituitary gland, what will happen to levels of CRH and ACTH? What was it? It's a decrease, right? So for primary, we'll have decrease of CRH, decrease ACTH, but because the cause is within the adrenal cortex, that's why it's called primary, there's going to be excess aldosterone, cortisol, and androgen. Negative feedback from the adrenal cortex will tell the hypothalamus that there's too much of these three hormones, and it's going to decrease production of these other, the CRH and ACTH, right? So you guys really know what negative feedback means and what it does, because it's pretty important, and I know for sure that there's going to be many, many questions that relate to negative feedback. Treatment, we'll just put some treatment down. Surgery, of course, but hormonal replacement. And what are some examples of synthetic cortisol? There's prednisone, cortisone, dexamethasone. If you see it in your PowerPoints, make note of it, but for now we'll just put hormone replacement of all three hormones or of the hypothalamic hormones. So, which disorder or disease is caused by deficiency of the adrenal cortex hormones? Starts with an A. Addison's. Right, so it's Addison's disease. Right, and as we said, it's deficiency of aldosterone, cortisol, and androgen. Primary is due to a problem in the adrenal cortex. And the symptoms. So deficiency of aldosterone, what do you think will happen to ions? Sodium, what's going to happen to sodium? Deficiency of aldosterone. Right, hyponatremia. And when we have hyponatremia, what's happening to the potassium? Increases, right? So hyperkalemia. As we said, blood glucose levels are indirectly affected by cortisol. What's going to happen to the blood sugar if cortisol is decreased? So hypoglycemia. And both aldosterone and cortisol have an effect on blood pressure. When there's deficiency of both, what's happening to blood pressure? Decrease, right? So hypotension. So the way that I think about it is Addison's is a decrease in everything but potassium, whereas Cushing's is an increase of everything but potassium again. Another symptom is hair loss. Which hormone causes the hair loss? Cortisol, androgen, or aldosterone? Which one? right? Androgen. So differential diagnosis between primary and secondary Addison's. There's a distinct symptom that you'll find in a patient who has primary Addison's versus secondary. You guys remember? Right, hyperpigmentation. So we won't find hyperpigmentation within a patient with secondary Addison's. But why not? Why won't we see this? Looking for a very simple answer. What causes the hyperpigmentation? POMC, right? But due to negative feedback, there's a lack of negative feedback within secondary Addison's. That's why they don't have hyperpigmentation, right? Do you guys understand what that means? Lack of negative feedback. So in primary Addison's, the problem is specifically in the adrenal cortex. There's a deficiency of all three hormones, correct? This will send a signal to the hypothalamus to increase production of CRH and ACTH. That's the negative feedback, right? That's primary Addison's. But for secondary Addison's, the problem is within the hypothalamus or the pituitary gland. So there's a deficiency of CRH or ACTH leading to a deficiency of aldosterone, cortisol, and androgen, right? But there's no hyperpigmentation because of POMC, proopiomelanocortin. So, do you guys remember where POMC was created or produced? Right, the intermediate lobe of the pituitary gland. It's stimulated due to feedback from the adrenal cortex when there's a deficiency of three hormones, like we said, increases CRH, ACTH, but a precursor or ACTH is made from POMC, right? POMC is a precursor for both, or not both. It's a precursor for, as we said, ACTH, endorphins, and what is the third one? This is what causes the hyperpigmentation. Starts with an M. Right. MSH, or melanin stimulating hormone. When there's an excess of MSH, this will lead to hyperpigmentation. Hyperpigmentation is the darkening of the skin color around the lips, the nose, nail beds, etc. As we said, secondary is within the hypothalamus or the pituitary gland. Symptoms will be the same as primary except for what we've been talking about. Right, hyperpigmentation. And this is due to a decrease of CRH, leading to a decrease of POMC and a decrease of ACTH and MSH. Good? MSH. So MSH will cause hyperpigmentation, correct? Yes. Right here, MSH. So although it's not on the review, I want you guys to write in right here. Review pheochromocytoma, right? There's a possibility it may show up on your exam. And what is pheochromocytoma again? Exactly. Specific tumor of the adrenal medulla causing excess secretion of which two neurotransmitters or hormones? Norepinephrine and epinephrine, right? This will cause symptoms such as hypertension, severe headache, excess sweating, raging heart rate like tachycardia, palpitations, nervousness, anxiety. So make sure you guys go over pheochromocytoma within your notes. The thyroid gland produces two hormones. We talked about T3 and T4. T3 is triiodothyronine, T4 is thyroxine. These are produced via the stimulation of TRH from the hypothalamus, which will therefore travel through the HPS or hypophysioportal system to the pituitary gland and bind to the trophic cells. That's more than you guys need to know, but then TSH will go to the thyroid gland and then stimulate secretion of T3 and T4. Blood supply is by the superior thyroid artery. We probably won't ask you this because it's more of an anatomy question. What's good to know? Superior thyroid artery, branch of the external carotid artery, and the lower portion is inferior thyroid artery, etc. Like I said, you guys don't need to know blood supply. It's more for anatomy. There's two lobes of the thyroid gland. Now, synthesis of thyroid hormones, right? There are two precursors. We have thyroglobin and iodide. The first step involves transport of iodide using a pump. Iodide is oxidized and converted to iodine. Right? So then the iodine will combine with tyrosine residue of thyroglobin. To form MIT and DIT. What is this process called? The iodine binding to a tyrosine residue to form MIT and DIT. Right, organification. So when there's a combination of two iodines with a tyrosine residue, or no, one iodine with two tyrosine residues, which one does that form? One iodine, two tyrosine. It's going to be DIT, so I was trying to trick you guys. If that makes sense, because there's two tyrosines, that's what makes it di. So if it's one iodine and one tyrosine, it's MIT, right? T3 is a formation due to a combination of, what was that? Right, DIT plus MIT. So if there's a di plus a mono, it equals 3, T3. T4 is combination of which two? Right. DIT with DIT. Again, like we said, T3 is triiodothyronine, T4 is thyroxine. Which one of the two is more active? T3. The thyroid hormone functions during pregnancy is important for the CNS development, the central nervous system, bone growth, and the reproductive tract, formation of it. T4 uses a thyroid binding globin, or TBG, enters the cell and is converted to T3, right? This will then join the protein, enter the nucleus, etc. to show their physiological effect. Before we move on, I'll mention this. T4 is able to pass through the placenta, right? If it can pass through the placental membrane, then it will form T3. This is for embryonic life, right? T4 can pass the placental membrane and then convert into T3. Regulation of thyroid hormones. From the hypothalamus, we have TRH. TRH will stimulate production of TSH from the anterior lobe of the pituitary gland. Right? TSH will act on the follicular cells of the thyroid gland, and it's going to form T3 and T4 through its mechanisms and actions of adenylate cyclase and increase of cyclic AMP. End result, T3, T4. T3 downregulates TRH receptors. Downregulate means negative feedback. When there's too much T3 and T4 in the body, there's negative feedback sent to the hypothalamus to decrease production of TRH and TSH, correct? Thyroid hormone functions is for body metabolism, temperature, heart rate, memory and learning, glucose absorption and glycogenolysis, along with protein synthesis and degradation. Hyperthyroidism has another name when it's an autoimmune disorder. What is this called? Hyperthyroidism, excess T3, T4. Starts with a G, Graves' disease. Right, so symptoms are weight loss, nervousness, headache, sleep disorder, heart disorders, enlarged thyroid. And what is that called when there's an enlarged thyroid? A goiter. Differential diagnosis. No hypernatremia. So look for that in your notes, actually. Don't take my word for that. Look within your notes for differential diagnosis of that. Yeah, hyper. In case she asked you the difference between primary hyperthyroidism and secondary hyperthyroidism, let's start off with primary. We're going to talk about the levels of hormones. For primary hyperthyroidism, there's going to be decreased TRH, decreased TSH, increased T3, increased T4. Again, like we mentioned, this is due to negative feedback. T3 and T4, when there's an excess, it will downregulate TRH and TSH. All right. Whereas for secondary, there's going to be an increase of TRH, increase of TSH, an increase of T3 and T4. All right, primary versus secondary. Primary, there's a problem within the gland itself, the thyroid gland, whereas secondary is within the hypothalamus or the anterior pituitary gland, right? Just in case, treatment for hyperthyroidism, we're going to need to use anti-thyroid hormone drugs. They're called thionomides. One is I can't fit it. So it's propyl thio Craciol. Can you guys see that? Propyl thio THIOCRACIAL. Another drug is propanolol, right? This is used for the excess, the tachycardia, because T3 and T4 can have an effect on norepinephrine and epinephrine. Does that make sense? Propanolol. Hypothyroidism. Primary occurs directly in the thyroid gland, whereas secondary occurs in the hypothalamus or the pituitary, specifically the anterior pituitary gland. Let's talk about the hormone levels of secondary versus primary. Starting off with primary. Primary hypothyroidism. Levels of T3, levels of TRH and TSH, right, for hypothyroidism. Increased TRH, increased TSH. But because it's hypothyroidism, we're going to have a deficiency of T3 and T4. Secondary hypothyroidism. Decreased TRH, decreased TSH, decreased T3 and T4. Right? So differential diagnosis, looking at these lab results, in primary we have decreased levels of T3 and T4, right? What's going to happen to TRH and TSH for primary? Increase. So we're going to produce more TRH and more TSH, depending on which gland it's affecting. In secondary, this does not occur due to a deficiency of TRH and TSH already, which causes the deficiency of T3 and T4. Some symptoms: weight gain, sleep disorder, weakness, dry hair and skin, right? Just know that she also mentioned Hashimoto's thyroiditis, correct? Hashimoto's thyroiditis is an autoimmune attack of the thyroid gland, which will cause, in 20% of patients, hyperthyroidism, and in 80% of patients, it'll cause hypothyroidism, right? It's usually an autoimmune attack of the gland, and once the attack's over, per se, the patient will have either of the two, 20% hyper, 80% hypo. Just keep that in mind. Hashimoto's thyroiditis. Congenital hypothyroidism is also known as cretinism. She may not have mentioned that in class, but another name I'll give to you guys. Cretinism. Right? It's going to be deficiency of T3 and T4. Leads to poor thyroid development. Leading to shorter stature, mental retardation, bone growth retardation, sleep disorders, speech disorders, all of the disorders, as we mentioned in class. Oh yeah, before we move on. So treatment, right? Just in case. Treatment, it would be hormone replacement ASAP. So as soon as possible, you're going to need to replace their hormones. And with that, we're going to use L-thyroxine. Right, so thyroxine is T4. And we know that T4 will convert itself into T3. The parathyroid gland, there's 4 different little parts of it, or 4 lobes, located posterior to the thyroid gland. Chief cells of the parathyroid gland will secrete or release, not secrete, it will release PTH or parathyroid hormone. Right? So principal function of PTH is to regulate blood calcium, exactly. Keep in mind that calcium has a direct correlation with phosphate. When there's increased calcium, there's decreased phosphate, right? So just keep that in mind as well. 3 places that PTH works to increase calcium. One, we have our bones, the epithelial cells of the small intestine, and in the kidneys for reabsorption of calcium. Dietary calcium, like from milk, etc. Alright, and vitamin D is important for reabsorption of calcium. So as we're talking about vitamin D, PTH will convert 25-hydroxycholecalciferol into its active form, 1,2,5-dihydroxycholecalciferol. Right? Any of you guys from biochem, do you remember like how to write it out as 1,2,5-OH2 something? No? Alright, so sometimes she likes to write it out as 1,2,5-dihydroxycholecalciferol, or sometimes she gets lazy. and writes it as 125 in like parentheses OH2 something, right? So just look for it written differently. I don't specifically remember exactly how it's done, but make sure you look for it and don't get confused. If you see 125, that's dealing with vitamin D conversion, okay? So vitamin D is going to act on the bone to promote the reabsorption of calcium. True or false? Parathyroid hormone decreases phosphate reabsorption by proximal tubule. I heard it true, right? Some important functions of calcium is control of our action potential. So action potentials, muscle contractions, and etc. But these are the two important ones, action potentials and muscle contractions, right? Hyperparathyroidism will lead to hypo or hypercalcemia. Right, so hypercalcemia. Hypercalcemia, patient will also have abnormal extrasystoles of the myocardium, increased heart rate, irritated CNS, and osteoporosis. Osteoporosis occurs because PTH takes calcium from the bone. Excess PTH, excess removal of calcium from the bones, will lead to brittle bones, osteoporosis, and etc., right? Hypoparathyroidism, hypocalcemia, muscle weakness, right? Because we need calcium for action potentials. Vitamin D deficiency can occur from a thyroidectomy, surgical removal of the thyroid gland. Sometimes the surgeon can nick part of the parathyroid gland as well. I mean, it's kind of hard not to if you're taking out the thyroid gland. In the pancreas, we have 3 types of hormones, right? The alpha cells will produce which hormone? Glucagon. The function is to increase our glucose levels and acts on the liver to increase gluconeogenesis and glycogenolysis, right? So would an increased level of blood glucose levels or decrease, which one will promote secretion of glucagon? High blood or low? Yeah, right. Low blood sugar. So hypoglycemia will stimulate secretions of glucagon. Beta cells will produce insulin, right? The function is to decrease our glucose levels and promotes uptake into the target cell by glucose binding to its receptor. It initiates a signal cascade to promote translocation of GLUT4 channels. Right? This will increase glucose for energy and cellular respiration. Good? Increase energy and cellular respiration. It's transported via facilitated diffusion. All right, in a specific tumor of insulin cells, also known as an insulinoma, will lead to increased secretions of insulin, causing hypoglycemia, and the patient can go through a hypoglycemic shock, or coma, not shock, coma. Yeah, sure. Right, exactly. My bad. So for I, part I right here, insulin will bind to its receptor, right? Thank you. So insulin will bind to the receptor, and then within the cell, it'll open up GLUT4 channels. The GLUT4 channels will allow for glucose to enter into the cell, increasing cyclic AMP, and etc. Make sense? Again, thank you. Delta cells will produce somatostatin. And as we know, somatostatin will suppress insulin and glucagon within the pancreas. It helps to maintain constant blood glucose levels. So we have type 1 and type 2 diabetes. Type 1 diabetes is an autoimmune destruction of beta cells. Right? Beta cells in the pancreas. This will lead to deficiency of insulin. We have treatment of insulin with synthetic insulin from IV or subcutaneously. We give it to the patient, intravenous or subcutaneous. Type 2 diabetes. Receptor insensitivity to insulin. Receptor insensitivity to insulin. Right, so this can be to obesity, right? Poor diet. When you have too much, throughout your lifetime, too much activation of your insulin receptors due to a poor diet, this can lead to damage to the receptors, which causes the receptor insensitivity, right? It's good to mention there are other types of diabetes that she mentioned. There was gestational diabetes, right? Diabetes during pregnancy. It's usually temporary. There is steroidal diabetes due to excess cortisol, right? And there's also diabetes insipidus. Diabetes insipidus is due to an excess or it's dealing with antidiuretic hormone, right? Excess antidiuretic hormone will promote polydipsia, polyuria, because we're not reabsorbing our water, right? So that's diabetes insipidus. And the differential diagnosis between type 1, type 2 diabetes versus the other three, well, first for one, gestational is just during pregnancy and it's not permanent. But with steroidal and diabetes insipidus, there's no problems with insulin and glucagon. It's due to other factors, right? So the general symptoms of diabetes is vasculopathy, calcification, hemorrhage that can lead to MIs, myocardial infarctions, and in the GI it can lead to malabsorption. In the kidneys it can lead to nephropathy. And when it's over levels of 350 milligrams per deciliter, so over 350, the patient will present with glucosuria. Glucosuria is urine within the blood. Glucose within the urine, right? Glucosuria. Type 1 diabetes treatment, insulin replacement via IV, intravenous, or subcutaneously. These patients cannot use oral medications because when they take synthetic insulin through the mouth, it'll be broken down by the gastric juices and therefore it's useless. For type 2 diabetes, these patients are insulin resistant. Hormone therapy is ineffective, like injecting with insulin, because they have receptor problems to start off with. So giving them insulin won't do anything, right? The medication we do use is called metformin. Metformin will act and decrease blood glucose levels. More treatment is exercise and diet, right? So for placental hormones, the first hormone secreted during pregnancy is HCG, human chorionic gonadotropin. I want you guys to look at this list, but also look at it within your notes and what she talked about in class, because she talked about a few more, right? So just refer to your PowerPoints and notes for this section of placental hormones, and read this on your own as well. Now, prostaglandin is a fatty acid precursor. Well, it has a fatty acid precursor. The arachidonic acid is converted into prostaglandin E2 by an enzyme called cyclooxygenase. Right? Promotes vasoconstriction or vasodilation. Can be harmful to our temperature centers. Which therefore will result in fever. Alright? To treat fever, we have to use a cyclooxygenase inhibitor. Such as aspirin, NSAIDs. This is in your PowerPoints. Ibuprofen, right? So just know that NSAIDs, or non-steroidal anti-inflammatory drugs, will block off cyclooxygenase, the enzyme, right? If we're blocking cyclooxygenase, we are blocking off the conversion of arachidonic acid into prostaglandin E2, correct? Right? Prostaglandin E2 also serves its purpose as for preparing the cervix for delivery and in males, erection. The pineal gland is located posterior to the third ventricle of the brain. Produces production of melatonin. from serotonin. It's going to regulate sleep. Increased levels happen during darkness. Right there. You said at C? Oh, right here? It's indomethacin. INDOMETHACIN. Good? Alright. 23, spermatogenesis. Development of sperm from germ cells is going to start at birth or with birth. The spermatogonia will mitotically divide to form the primary spermatocyte, right? Then this undergoes the first meiotic division to form two secondary spermatocytes. Second meiotic division will form 4 spermatids. This will undergo spermiogenesis to form 4 mature sperm cells. Which cells regulate spermatogenesis? Is it Leydig cells or Sertoli cells? Right, Sertoli cells. The structure of the sperm, the head or the end of it is called the acrosome. This contains acrosin, prostaglandin, and ACE. What are these functioned for? It just protects and prepares the sperm, and it prepares the female reproductive tract, right? So that fertilization can occur. For male reproductive system, the hypothalamus will release GnRH, gonadotropin releasing hormone. Right? This will stimulate secretions of LH and FSH. The Sertoli cells regulate spermatogenesis, right? And they secrete inhibin. This controls spermatogenesis by inhibiting FSH, GnRH, right? So the FSH will act on Sertoli cells to form receptors to respond to testosterone. This is another example of negative feedback. When we have too much testosterone, inhibin is secreted. It'll tell the hypothalamus to decrease production of FSH and LH. So the Leydig cells secrete testosterone, right? The sperm contains different types of factors, right? This will help it travel throughout the female reproductive tract, giving it energy, making for fertilization to be successful. Some of these factors are zinc, prostaglandin, calcium, fructose, and mucus. As I said, is there to protect the sperm and also prepares the female internal environment for successful fertilization. Erection is when blood fills the corpus cavernosus by activation of the sympathetic or parasympathetic nervous system. Erection. Right, parasympathetic. This causes vasodilation, causing erection, right? You can use medications such as nitric oxide. Emission, the travel of sperm throughout the tract, is that by parasympathetic or sympathetic? Sympathetic. The sympathetic nervous system. And whereas ejaculation is controlled by both parasympathetic and sympathetic nervous system. Right? Oogenesis starts at the germ cell to differentiate into the oogonia. It undergoes mitosis to form the primary oocyte. Right? Females have a shorter reproductive life. They have a limited amount of eggs, whereas in males, they have pretty much an unlimited reproductive life. They constantly produce sperm, right? In females, it's just during this time. And it's suspended state until puberty, the oocytes, by secretion of oocyte maturation inhibitory factor. Right, so OMI, oocyte maturation inhibitory factor. Puberty triggers second meiotic division, and then it's going to form secondary oocytes, which therefore these can be fertilized by sperm to form an ovum. We have Klinefelter syndrome. Klinefelter syndrome is a patient that has XXY, right? Their genotype is male, but their phenotype is female. They'll have feminine characteristics, intersexuality, and infertility. How many chromosomes are in a sperm and in an egg? Right? 23. Whereas a zygote has 46. So menstruation, there's 3 phases that she talked about. The first is follicular phase. Right? Development of the follicle by FSH. Second is the luteal phase. This is during days 13, 14, and 15, the mid-cycle. Right? LH levels spike just before formation of the corpus luteum. Mid-cycle is when most successful fertilization can occur. Days 14 to 28, the secretory phase. This is when the endometrium will build back up if there's unsuccessful fertilization. Pregnancy, human chorionic gonadotropin, is important for maintaining the endometrium by the corpus luteum. The corpus luteum CL's corpus luteum is for secretion of progesterone during the first trimester, right? First trimester of pregnancy. After that, the placenta will take over production of progesterone. Right? So the corpus luteum will then degenerate. And the placenta also secretes other hormones. We mentioned before the placental hormones. Look back on that list and also in your PowerPoints and notes. Now let's talk about the immune system because it is going to be part of this test. We have two types, innate and adaptive immunity. Innate immunity triggers, oh, what the heck, I'm sorry. Innate immunity is the first line of defense, right? Always think of innate immunity as first line, and it will always involve the neutrophils first, then the macrophages and etc., right? Correlate innate with neutrophils, first line of defense. Adaptive immunity takes longer. Always know that it takes longer, and correlate it with T and B lymphocytes, or T and B cells, right? Fever, temperature center is located in the hypothalamus. Prostaglandin E2 will trigger the fever or pyrogen, and this is synthesized from arachidonic acid by the actions of an enzyme called cyclooxygenase. Right? So aspirins or NSAIDs will reduce and suppress fever by inhibiting the enzyme cyclooxygenase. So inhibiting cyclooxygenase will therefore hinder the conversion of arachidonic acid into prostaglandin E2, right? You guys can read that. T and B cells, adaptive. Natural killer cells respond to viruses or innate immunity. We have some immunoglobulins. IgA is common in saliva and breast milk secretions. IgE for allergic reactions. IgG, these can cross the placental barrier, right? This gives the fetal immunity. For the complement system, this coats antigens to mark for macrophages to detect. Sorry, that's bad wording. But this process is called, yeah, exactly, opsonization. Right? Opsonization. The complement system or the membrane attack complex will be from C5 to C9. Put a bunch of stars around that, all right? C5 to C9. So if you're presented with a question is what does the complement system or what is it made up of, you see like C4, C2, C8. Which one would you choose? C8, because it's part of C5 to C9, right? That's just an example. All right? So some disorders that you can look at, type 2 diabetes, Graves' disease from the past. And that's it. Any questions? Make sure if you guys could, there's the survey link on the sides and middles of the table. If you could, go to the website and take the survey, that would be nice. was it? Oh, I want to wish everybody good luck, all right? This is the final review. It's been really good working with you guys. It's been a pleasure. And you guys are going to do great, for real, all right? Thank you.